Hello, my name is Mark Kennedy. I'm a Senior Program Manager in the Chronic Disease Prevention and Control Division, which is a division of the Community Initiatives Bureau at the Boston Public Health Commission. I'm also co-chair of the Prostate Cancer Work Group for the Massachusetts Department of Public Health Comprehensive Cancer Prevention and Control Network. I have no disclosures. In this module, I'm going to set some familiar context, then explore the following questions with regard to screening and shared decision-making for prostate cancer for African American men. What constitutes high risk for prostate cancer overall? Are considerations for prostate cancer screening different for African American men? What constitutes harm and benefit associated with PSA testing for African American men? I'll explore what the guidelines say about PSA testing in the specific context of African American men. Then whether the goals of screening might be looked at differently for African American men and how shared decision-making factors in. From there, I'll show a short video that was produced by the Massachusetts Department of Public Health that depicts how a shared decision-making conversation between a patient and a provider might go. And I'll make some comments about how it could change based on what will have previously been discussed. And before I wrap up, I'll describe a risk-based screening protocol that provides parameters for those that choose to screen for this population. Let's start by setting some context. First, as we know, prostate cancer is one of the most common cancers that affects men. These data from the Centers for Disease Control and Prevention indicate that in 2014, prostate cancer was the second leading cause of cancer among all races and among whites, and the leading cause of cancer among African Americans. The CDC estimates that more than 2.5 million American men were diagnosed and living with prostate cancer in 2013. Prostate cancer is the second leading cause of cancer death in men behind lung cancer. In 2014, 172,258 men in the United States were diagnosed with prostate cancer, and 28,343 men in the United States died from prostate cancer. While the overall incidence has declined, African American men are 60% more likely to be diagnosed with prostate cancer than other men. And while overall mortality has declined, African American men are 2.3 times more likely to die from prostate cancer than other men. So with that context, let's look at the overall goals of screening for prostate cancer. One, of course, is to save lives. The U.S. Preventive Services Task Force, in its now final updated guideline for prostate cancer screening, addresses preventing morbidity as well. Both of these accomplished by identifying lethal prostate cancer while it's localized. That statement also highlights the strategic relationship between screening and treatment. So what constitutes risk? Let's start with the well-known risk factors for prostate cancer: age, race, and family history. These will factor into the decision to be screened, but race and family history as predictive factors for lethal prostate cancer are not as strong as baseline PSA value. I'll discuss this more later. The introduction of PSA-based screening for prostate cancer has substantially altered the epidemiological data for prostate cancer by greatly increasing the number of men with a diagnosis of prostate cancer, and thus the number of men with a father, son, or brother with a diagnosis or history of prostate cancer. This broadening of the number of men perceived to be at high risk indicates that with regard to risk, PSA testing feeds on itself based on the use of race and family history as risk factors. As we know, there are several factors that can contribute to a high PSA before the consideration of prostate cancer. Frequent, routine, or opportunistic screening exposes men to more opportunities to experience the harms associated with screening. As with the previous slide, we routinely associate high PSA with prostate cancer, while we know that PSA is prostate-specific and not prostate cancer-specific. So patient anxiety can possibly be avoided with education and a different positioning of what the PSA really is. Then there are the issues of overdiagnosis and overtreatment. Are considerations for prostate cancer screening different for African American men? That case can be made considering that African American men are diagnosed younger, present with more aggressive disease when diagnosed, and are at higher risk for metastatic disease than other men. And as we've seen, mortality rates are historically higher compared to white men, and that disparity persists. In making the case, one could view many of the issues that underpin the controversy around prostate cancer screening as a matter of public health, and rightfully so. Given the fact that prostate cancer affects a specific population so differently, the conversation for African American men is more of a population health issue, and perhaps should be looked at as such when we consider the reasons, goals, and approaches to screening. What are considerations of harms on the prostate cancer continuum for African American men? Prostate cancer represents a true spectrum of disease, such that not all men that are diagnosed with prostate cancer require treatment, and certain men, based on their risk profile, are disproportionately impacted by the disease. As such, early detection strategies that don't recognize the importance of refined and selective diagnosis and treatment may cause harm. The screening strategy and the treatment strategy should be linked in the most ideal case. In fact, of course, with evidence notwithstanding, the treatment strategy would actually drive the creation of the screening strategy, again, in a perfect world. So isn't the treatment strategy for prostate cancer to cure men with lethal disease? Isn't the strategy to avoid unnecessary treatment? Are existing screening strategies supporting these treatment strategies properly? If not, it's no surprise that the early detection strategy can cause harm. And this is especially true for men that are disproportionately impacted by the disease based on their risk profile. With regard to refined and selective diagnosis and treatment, if active surveillance, which is increasing in acceptance, is not taken into proper account in the discussion of harms and benefits, and we continue to couple issues with aggressive treatments with the decision to be screened, we cause harm to high-risk men that don't get the screening simply because of their concern for treatment side effects and subsequently present with late-stage disease. As I said before, African American men are diagnosed with prostate cancer younger, with more aggressive disease, and are at higher risk for metastatic disease. An important way to look at this issue of harm associated with PSA testing is to contextualize it in terms of outcomes. And in that context, a troubling picture emerges for African American men. Considerations of harm for African American men, in addition to the well-known harms, also have prominent social determinants and clinical practices components. And the outcomes based on these issues also cause harm. In terms of what impacts outcomes, do existing guidelines exacerbate the issue of harm for African American men? Guidelines on prostate cancer screening have been issued by several organizations, including the American Cancer Society, the National Comprehensive Cancer Network, the American Urological Association, of course, the U.S. Preventive Services Task Force, the Massachusetts Health Quality Partners, and outside of the United States, the European Society for Medical Oncology, and the European Association of Urology. The guidelines differ in their recommendations regarding whether or not to provide routine PSA testing, in what age groups, and at what intervals. The guidelines do agree that PSA-based prostate cancer screening requires an informed, shared decision-making process, and the decision should reflect the patient's understanding of the possible benefits and risks and should respect the patient's preferences and values. The U.S. Preventive Services Task Force recently changed its 2012 recommendation against PSA testing for prostate cancer. The current recommendation applies to adult men in the general population. The task force identified screening for prostate cancer in African American men as an area where evidence gaps prevented it from making a specific, separate recommendation. They indicate that decision analysis models suggest that given the higher rate of aggressive cancer in African American men, PSA-based screening may provide a greater benefit to African American men than the general population. These models also suggest a potential mortality benefit for African American men when beginning screening before age 55. The task force believes that a reasonable approach for clinicians is to inform African American men about their increased risk for developing and dying from prostate cancer, as well as the potential harms and benefits of screening, so that they can make an informed personal decision about whether to be screened. This Medscape article about the 2012 task force recommendation highlights an increase in cancers with higher Gleason scores, as well as an increase in median PSA levels in the 4 years after the task force recommendation was released compared to the 4 years before the recommendations were issued. And at the same time, both surgical volume and the proportion of low-grade cancers have been dropping. Another comment in this article was that treating high-risk disease has its limitations because, of course, you're not going to cure the majority of patients no matter what you do, so the better answer is to diagnose prostate cancer earlier. In another study designed to assess the impact of the 2012 task force recommendation among urologists and primary care providers, showed that the recommendation did exactly what it was intended to do. The number of prostate cancer diagnoses dropped by more than 12% just in the first month after the draft guideline was issued. Diagnoses of low-risk cancers fell by 37.9% 12 months after the draft guideline was published, and continued to fall more rapidly than other disease risk strata. However, more men are now presenting with higher grade, more invasive prostate cancer. So while the recommendation may have reduced the risk of overdiagnosis and overtreatment for a lot of men, the reduction in intermediate and high-risk prostate cancer diagnoses raised concern because of the potential for delayed diagnosis of important cancers in men who might benefit from treatment. The AUA recommends against PSA testing in men under 40 and does not recommend routine PSA screening in men ages 40 to 54. For men younger than 55 years old and at high risk for prostate cancer based on positive family history and or African American race, decisions regarding prostate cancer screening should be individualized. The National Comprehensive Cancer Network recommends performing a baseline evaluation with a history and a physical examination that includes the following: family history, medications, history of prostate disease and screening, including prior PSA exams and biopsies, and then, of course, race, family or personal history of BRCA1 and 2 mutations. The clinician should then discuss the risks and benefits of a baseline PSA test with the patient and consider a baseline GRE to identify high-risk cancers associated with a seemingly normal PSA. In patients 45 to 75 years of age, subsequent evaluation is based on the results of those tests, with intervals directly based on risk. These guidelines are favorable to high-risk men. So, with specific respect to African American men, what do the guidelines actually say? With the treatment strategy being to save lives and eliminate morbidity associated with late-stage disease or unnecessary treatment, is the screening strategy aligned with the treatment strategy? Do African American men have the same opportunity for optimal outcomes? Starting age has to be considered in a population that is diagnosed comparatively younger and with more aggressive disease at younger ages. Also, intervals in many cases are set to avoid overdiagnosis, not to individualize screening according to patient risk as determined by PSA level at baseline. Considerations of starting age and screening intervals are population health issues. A population health perspective addressing the gray area between what the evidence says and the fact that populations that suffer the biggest burden weren't adequately represented in the research. Then there are the systematic issues, including racial disparities that exist at stages of presentation, diagnosis, and treatment, which impact subsequent survival and quality of life, including unnecessary treatment for African American men based on managing legal risk associated with not treating them, or undertreating or not treating at all in cases where they could benefit from treatment. In fact, for many men, where they live and what doctor they see may have more to do with the care they get than clinical condition and what they care about. For African American men, this typically results in worse treatment and worse outcomes. Recent studies have shown that treatment for prostate cancer varies based on provider and clinical institution, and that healthcare providers should be aware of inherent bias when counseling patients on treatment options for localized cancer. Another comment about that same study says that we need to do a better job from a system-level perspective regarding prostate cancer counseling and recommendations, and that there should be no reason why there is such a variation in how African American men are treated from one institution to another. The study found that 39% of the 356 facilities that were in the study were significantly more likely to give aggressive therapy to white men than to African American men, both diagnosed with intermediate and high-risk prostate cancer, for which treatment would have given the best odds for survival. So here's a snapshot of the harms and benefits of prostate cancer screening for African American men. In addition to the well-known harms, additional considerations need to be discussed, and the discussion should properly balance risk and benefit to mitigate avoidable harms. Shared decision-making is the common denominator. Shared decision-making has both an educational as well as a decision-making component. And if we elevate the education, many harms can actually be avoided, including those that relate to clinical practice issues. In an accompanying editorial to the final recommendations from the Task Force for PSA Testing, Dr. H. Ballantyne Carter wrote, the new U.S. Task Force guidelines take a thorough approach to assessing the pros and cons of PSA testing for prostate cancer screening, and they highlight the importance of identifying populations who could most benefit from screening and treatment. He endorsed a 2 to 4 year screening interval to help reduce false positive test results and overdiagnosis. And he went on to say that by virtue of their relationship with patients, primary care physicians are in a unique position to help ensure that men diagnosed with favorable risk disease, which is Gleason score 6 cancer grade on biopsy, and PSA levels of less than 10 nanograms per milliliter, are presented a balanced message regarding management options with active surveillance as the preferred choice. So let's revisit the goals of screening in light of what's been discussed so far. Because there is a population that's disproportionately impacted by prostate cancer, and that population is well defined, the right approach to prostate cancer screening can have benefits. All of these address catching cancer while it can be cured. So if the treatment strategy is to cure prostate cancer and reduce morbidity and mortality, does the screening strategy support that? And does it support that for all men? When you read these in ascending order, you realize that in order to do this, screening has to be done based on risk. So what are the goals of shared decision-making in prostate cancer for African American men? Of course, we want to reduce the harms and increase the benefits. We can do that by educating African American men basically about the prostate. I think a decision about the health of a particular part of the body should be accompanied by what that part of the body does and what the implications are of having disease or issues in that area. We also need to educate African American men properly about risk, including the non-clinical issues. We also need to educate men about the need to ask for the screening. We need to increase the probability through SDM that the right men are getting screened. We also need to increase the probability that the right men are continuing screening after they get a baseline and at the proper intervals. Repeating the discussion about the pros and cons of testing as new information about risk and benefits become available and as changes in a man's health, values, and preferences occur is also a very important part of the goals of shared decision-making, particularly for African American men. Can systemic harms be mitigated to improve outcomes for African American men on the prostate cancer continuum? Well, of course, we can reduce the harms and increase the benefits associated with PSA testing by removing avoidable harms. We can ensure equitable access to quality care, and we can reinforce that screening and treatment require a rational approach with education and shared decision-making. That way, we don't miss diagnosing aggressive disease and we don't overtreat indolent disease. So here's an overview of what education-driven shared decision-making processes for prostate cancer screening in African American men might look like. Again, it's important to recognize that the shared decision-making for African American men should pay close attention to the educational component. Men need to clearly understand, as I mentioned before, the function of the prostate, how it naturally changes over time. Men should also have a clear understanding of the differences between indolent and aggressive disease, so that as the harms associated with treatment options are discussed, they can have a more objective approach and appreciation of active surveillance. This will address the common view that all cancers are dangerous and require treatment, and will possibly mitigate the patient-driven issue of overtreatment to a large degree. There should also be a clear distinction between risk associated with the decision to be screened versus the risk of being diagnosed with a potentially lethal prostate cancer. This distinction will inform the decision to continue screening and at what interval. Let me now show you the video produced by the Massachusetts Department of Public Health on shared decision-making in prostate cancer for high-risk patients.
Okay, before we wrap up today, I'd like to talk to you about prostate cancer. You may know that African Americans and other black men are at a higher risk for prostate cancer than white men. And the risk increases starting at age 40. So to give you an idea, about 1 in 5 black men will be diagnosed with prostate cancer in their lifetime. For 1 in 22 black men, it will be the cause of their death.
My grandfather had prostate cancer, so it runs in my family too.
Your family history probably puts you at somewhat higher risk, but not as high as it would be if you had a brother or a father with prostate cancer. Here's the thing. Doctors don't all agree about testing. There are pros and cons to the test. Getting tested every 1 to 2 years could reduce your risk of dying from prostate cancer by 20 to 30%. But the test can also lead to some harm. For some men, not getting tested and avoiding the harm is the right choice, even though they lose a small benefit. It's complicated, so let's talk it through, and we don't have to come to a decision today.
Okay.
So, PSA stands for prostate-specific antigen. The test for prostate cancer is a blood test that measures your PSA level. A high PSA level might mean prostate cancer, but it could also mean things that aren't cancer, like an enlarged prostate. Does this make sense so far?
Yeah, I think so.
Because we don't know for sure what's causing a high PSA level, we do more tests to find out. If more tests showed that the likelihood of prostate cancer was high enough, then I might recommend a prostate biopsy.
So what would happen if the biopsy showed cancer? I would have surgery to remove it, right?
I wish there was an easy answer to that. But not all prostate cancer is harmful. The action we take would depend on how likely it is that the cancer we found will cause harm.
But I thought all cancer was dangerous and could spread.
Well, unlike a lot of other types of cancer, most prostate cancers grow very slowly and won't cause problems or need treatment. So treating these cancers could do more harm than good. But harmful cancers can spread, and treatment is needed to stop them. The tough part is that we can't always tell which cancers are harmful and which ones would grow slowly and never need treatment.
If you did find the harmful kind, what would treatment be?
Well, treatment is usually surgery, radiation, or both. There are side effects, like urine leakage. Some men also experience impotence. They can no longer get an erection. Blood clots and heart attacks are much less common, but those are possibilities following any major surgery. So what do you think about these?
I don't think those side effects are as bad as living with cancer. I'd want to get treated and not have cancer in me.
Okay, that's good for me to know. If I was confident that a cancer was most likely harmful, I'd recommend treatment in most cases. But if the cancer didn't appear to be harmful, there would be another option called active surveillance. Choosing this option could mean that you'd avoid the possible side effects of treatment.
Can you explain that option?
Sure. We would keep a close eye on your prostate for a long time by doing a PSA test every few months and repeating the biopsy from time to time, maybe even doing an MRI of the prostate too. And if the cancer grows, we'd reconsider treatment.
Is active surveillance safe?
We're still studying it, and there's a lot we don't know for sure. There's some risk with active surveillance that cancer cells could spread before we see the cancer is growing. At that point, it may be too late for prostate surgery or radiation to cure the cancer. So what do you think about this, the active surveillance route? I know you said earlier that you wouldn't want cancer inside of you.
Yeah, I don't think I want to wait to do something if I knew there could be harmful cancer inside of me.
Okay. Remember to keep in mind that just because you have a risk factor doesn't mean that we would definitely find harmful prostate cancer. For every man who's been diagnosed by a PSA test and is cured, 20 or more will have a prostate cancer diagnosed and will not benefit from treatment, usually because the cancer isn't harmful. It's important for you to know before you do the test that if we did find cancer, and I was confident that it wasn't harmful, I may recommend active surveillance. So does that make sense?
Yeah, I see what you're saying. You want to be sure I understand what could come down the line before I decide about the test.
Right. But for now, the first thing to consider is the test. Then there may be decisions after the test, like we've talked about. So it's good for you to know about these things as you consider what's right for you. You don't have to make a decision right now, but I'd like to know how you're feeling about getting the PSA test.
I think I should probably get the test, especially since the prostate cancer's been in my family. But I'm not sure about the active surveillance that you explained and whether I'd be okay with that. Would you recommend I get the test?
I recommend patients do the test only if they're really sure it's right for them. For today, I suggest you take this information with you. It has answers to common questions men have. We can talk about it more when I see you in a couple of months.
Thanks. I'll take a look and talk about it with my family, too.
That sounds good.
The video was very well done, but I do have some comments. The video focuses heavily on the side effects of treatment. While there are obviously a consideration in terms of harm, there could be more balance in the discussion based on what's at risk if lethal prostate cancer is not detected early. So from an individual risk perspective, men who may have potentially lethal prostate cancer could decide to let their cancer go undetected based on the fear of side effects versus preferences, values, or other considerations. Also, there are many aspects of the discussion for high-risk men that are the same as the discussion for average-risk men. A key point in this regard is there is a reference to a small benefit, and that small benefit reference in the discussion is made by the provider instead of allowing the patient to make that determination after an indication of individual risk, possibly from a baseline test. Here are some suggestions for physicians considering shared decision-making in a clinical flow. One suggestion is to train staff at the clinic to conduct the educational component immediately prior to seeing the physician. Another is to schedule a separate visit with a patient to engage in shared decision-making to ensure focus on the content and not to interrupt other services during a visit for other issues. Black men use community health centers much more often as their first line of clinical service. Physicians in any type of clinic that is either located in an area that is populated with a majority of high-risk patients or for any reason has a high proportion of high-risk patients in its patient population should be prepared to provide concordant clinical service. Because there's a population that's disproportionately impacted by prostate cancer, and that population is well defined, the right approach to prostate cancer screening can have benefits. In a small study done at the Mattapan Community Health Center to assess whether education about prostate cancer screening would increase baseline testing in a high-risk population, the data indicated that formal PSA screening education prior to meeting with a physician was welcomed, and that screening provides an opportunity to develop an individual prostate health management program based on individual risk profiles that carefully monitor PSA fluctuations. Also, moving from race to risk, as we see here, provides a more precision approach to screening. With respect to the prostate cancer continuum, I see this as a way to re-educate both patients and providers with regard to establishing clinical risk that can be used to more effectively manage African American men and all men through the continuum. So, what are the characteristics of a baseline PSA test in the context of a prostate cancer screening protocol? Well, a PSA test is typically performed on men younger than age 50 to help determine their future risk for potentially lethal disease. The test can be used to set risk-based prostate cancer screening intervals, and it's usually the first test that a man has. The National Comprehensive Cancer Network lays out an effective baseline testing protocol involving men at a range of ages that include younger men who might be at higher risk based on their race and positive family history. The protocol includes comprehensive data gathering about individual and family history, after which shared decision-making is discussed to enable an informed choice on whether to have a baseline test. If a baseline test is chosen, screening intervals are set for men based on risk, as indicated by the results of the baseline test. Also, in 2013, a nonprofit organization called the Prostate Health Education Network created a consensus statement to provide guidance for PSA testing for African American men, in lieu of a level 1 study following PILCO and the European randomized study of screening for prostate cancer, given that the disparate burden of prostate cancer in African American men continues to exist. There are 3 statements involved with this consensus statement. The first is that baseline PSA testing for African American men and other men deemed to be at higher risk for prostate cancer is suggested to begin at age 40. This will allow us to predict future risk of prostate cancer. The second statement is that PSA testing should not be considered on its own, but rather as part of a multivariate approach to prostate cancer early detection. And last, prostate cancer diagnosis must be uncoupled from prostate cancer intervention. So, let's wrap up. First of all, let me say that since not all black men and men with a family history will die from prostate cancer, shared decision-making driven education creates the opportunity for African American men to properly assess their individual risk. Baseline testing, should men choose it, can be a benefit of screening for African American men and makes shared decision-making a more valuable tool. With the clearer understanding of the difference between aggressive and indolent disease, men will know to ask their oncology specialists if the disease is potentially lethal or not when diagnosed, which can lessen overtreatment. Higher confidence in this regard can lead to decisions about screening and treatment that more accurately reflect patient preferences. In addition to these considerations, proper education can reduce panic-related patient decisions about treatment and mitigate the overtreatment of prostate cancer. Education will also help to uncouple the risks of overtreatment with the higher risk of overdiagnosis. Last but not least, there's a variety of evidence on the horizon, and the evidence clearly supports more than one approach. Education is a critically important element of shared decision-making for African American men. Thank you for your time and attention, and I hope you enjoy this module in these sessions. Thank you.